following video represents open reduction internal fixation of a displaced clavicle fracture. The indications for surgical treatment are many, and most of these indications are relative. Displacement and increase in comminution has been associated with an increased risk of non-union with non-operative treatment, and shortening has been associated with functional deficit. Other relative indications include associated injuries, including vascular injury requiring repair, and also notably the floating shoulder is a relative indication for surgical management of the clavicle. Several patient factors should be considered, with polytrauma patients requiring early upper extremity function and patient requiring rapid return of function are other relative indications for surgical management. Non-union has been shown to be associated with comminution, displacement, advanced age, and male gender. All four of these risk factors, the non-union rate is nearly 50%. These represent preoperative radiographs of a displaced clavicle fracture treated with open reduction internal fixation. Here are the landmarks visualized from above. The standard incision is along the anterior-inferior border of the clavicle. This video will show an anterior-inferior plating technique. The incision for this technique is nearly identical to a standard, more traditional superior plating technique. These subcutaneous tissues are divided with the bovia seen here, and great care is taken to minimize periosteal stripping from about the fracture. Larger cutaneous nerves are identified and preserved. Many of the clavicle fractures have stripping of the periosteum relative to the trauma, and great care should be taken during the surgical dissection to minimize any further stripping to maximize the healing potential. This particular fracture has three main fragments. Here is the medial fragment, the central butterfly fragment, as well as a lateral fragment. The fractured surfaces are debrided and cleansed to allow anatomic reduction. Here, the butterfly fragment will be reduced and fixed initially to the lateral fragment. A reduction clamp is utilized, and you can see that the majority of the soft tissue attachments to the butterfly fragment as well as the lateral fragment are preserved. This is demonstrating the reduction of the lateral composite to the main medial fragment. The butterfly fragment is held with reduction clamps, and then a lag screw is placed in standard fashion by over-drilling the near cortex and then drilling the far cortex. Since this is an anterior-inferior plating technique, this lag screw would be sitting under the plate, and therefore it is countersunk. The depth gauge is used in standard fashion, and the appropriate length screw placed, and as you'll see, is nearly flush with the anterior-inferior surface of the clavicle, allowing the plate to be placed directly over the lag screw. The appropriate length plate is selected. Many systems have pre-contoured plate, and this pre-contoured plate is designed for the anterior-inferior plate location. Due to the high variability of the anatomy of the clavicle, even the pre-contoured plates sometimes require additional custom contouring. Here the main medial fragment is reduced to the lateral composite. The AC joint is identified and marked here with an angiocath needle. This provides a landmark for the most lateral position of the plate. The anterior-inferior plate is applied just medial to the AC joint across the fracture with at least 4 holes on either side of the fracture. As will be seen in a diagram to follow, the anatomy of the clavicle is such that it is very narrow laterally, and hence this plate tapers near the AC joint and allows 2.7 millimeter screws, where larger standard 3.5 millimeter screws are used for the shaft. The plate in this case is applied to the lateral fragment and secured with multiple screws. The majority of the screws for clavicle fracture fixation are non-locking. Lock screws may be utilized in the metaphyseal region out laterally and in cases where there's substantial osteoporosis. Here is the diagram showing the anatomy and the cross-section of the clavicle. As you can see, laterally the clavicle is very thin in a superior to inferior direction, but is quite wide anterior to posterior. Therefore, these lateral screws placed through the anterior-inferior plate are relatively long, usually approximately 24 to 26 millimeters. Screws placed through a superior plate, this lateral, are typically only 10 to 16 millimeters in length. Here, a lock screw is firmly secured to the plate in the lateral metaphyseal region of the clavicle. After completion of the lateral fixation, the reduction of the fracture is confirmed and the plate is secured to the medial fragment. Depending on the fracture pattern, lag screws can be applied through the plate across the main fracture. If amenable, the fracture pattern may be fixed with a lag screw outside the plate. Here the plate is secured to the medial fragment with a non-lock screw. Final screw is inserted near the fracture such that there are 3 screws supporting fixation in the medial fragment with empty holes left between the screws. The reduction is anatomic. Here you can see the relative positions of a superior plate to the anterior-inferior plate. These surfaces are essentially 90 degrees orthogonal to one another. Here's looking from the medial side. You can see the superior plate 90 degrees from the anterior-inferior plate. The wound is closed in the standard fashion, typically with multiple layers. It is preferred to have some closure of the deep tissues over the plate to minimize skin irritation. After the deep tissues are closed, the skin is closed in multiple layers using a subcuticular stitch and typically nylon sutures on the skin. Allgauer Donati stitches are useful to preserve the vascularity of the skin and provide for a relatively nice cosmetic closure. These are the postoperative radiographs showing the anterior-inferior plate and an anatomic reduction of the fracture. You can see another oblique view. This plate essentially covers the entire length of the clavicle. The results of operative treatment in a meta-analysis have been superior to non-operative treatment, but are associated with slightly higher complication rates.